Well, good afternoon. I know some of you have just joined and there's others joining, so we'll just give it about 2 minutes before we do introductions and start the program. But I just wanted to remind everyone that you will have the opportunity to ask questions in the side panel. There's a chat section, and then we will send out slides after the presentation as well. All right, we're going to go ahead and get started. My name is Jennifer Majori. I am the Executive Director for the National Association for Proton Therapy, and I'm very happy today to be able to introduce our panelists and also offer this educational opportunity to our members and the proton community at large. NAPT is committed to providing information and resources for the proton community as part of our mission, especially with the limitations of travel and conferences being virtual. We wanted to make a commitment to offer you education throughout the year and make sure that conversations regarding best practices in proton therapy continue despite our inability to get together and be together for these educational opportunities. We developed an education committee in the last 6 months after our conference, and I'm very happy that we've been able to offer some of these webinars to you all through the rest of the year. In addition to this webinar today, we also have one coming up next week that we collaborated with Isotech, so you will get an invitation to that as follow-up, and I encourage you to attend that as well. As I mentioned right at 3 o'clock, but in case you're just joining, we do have the opportunity for questions and answers. So this is a live presentation. Please give us your questions. We definitely want to make sure we address as many as possible. So you'll be able to do that in the chat section, and I believe there's a Q&A section as well, although I cannot see it as a panelist. I encourage you to use those to be able to reach out and let us know what your thoughts are and questions are regarding the program today. With that being said, I wanted to thank C-RAD for collaborating with NAPT and offering this educational opportunity. They've put together a great presentation, and so we have Mark Pankuch, who is the Director of Medical Physics and Dosimetry at Northwestern Medicine Proton Center in the West Region. He did receive his PhD in medical physics from Rush University. He's been an active member of NAPT. He also describes his C-RAD system as a complete home run in helping to accurately position proton therapy patients for treatment. We also have Chen Liu. He's a medical physicist at Northwestern Medicine as well. He's in the office with Mark, so he'll be joining the second half of the presentation. He received his master's degree in therapeutic medical physics from the University of Toledo and completed his residency training at Erlanger Health System in Provision Healthcare. He was instrumental in setting up the surface imaging program for proton therapy at Northwestern Medicine. And I'm very happy to have Dr. Chenguang. He is our moderator today. He is the chief proton physicist at Inova Health System. He's a member of our NAPT Education Committee, and he will moderate the program and make sure your answers are, your questions are answered throughout. So now, Mark, I'll turn it over to you to begin the program.
Great, thanks, Jennifer. And thanks everyone for joining us, and I want to thank the NAPT for giving us this opportunity, and also thanking C-RAD for letting us be part of this. And my partner here, Chen, he will give a part of the talk also with us. So neither of us have anything that we want to disclose here. So today's discussion, hopefully we'll maybe take a little break away from all the excitement in the world going on right now and talk something very exciting, surface imaging. And so today we want to talk about just the pathway that we had specifically for our existing center that's now 10 years old, how we got into image guidance. I'll give a little insight on where surface guidance fulfills a need, a specific need for us where other image guidance systems cannot. And then Chen's going to step up and talk about some cases where specific for us where surface guidance has improved our treatments. And then he's going to share some of our lessons learned so far from our limited program. So first of all, just to give you guys a little background, remember our center, even though we're 10 years old now, was initially a collaboration of 3 groups. So ProCure, Radiation Oncology Consultants, who are a physicians group, and Central DuPage Hospital. And they all came together and they made the ProCure CDH Proton Center. But since then more things happened, and CDH merged with Del Nor Hospital, and they became a center called Cadence Health. And Cadence Health had lots and lots of money, so they bought out ProCure's part of this whole establishment, and they became just part owners, and so we were just the CDH Proton Center. Then Cadence Health actually merged with Northwestern downtown and became a big group called Northwestern Medicine. And so Northwestern Medicine then changed the name with us one more time, and now that's why we're this Northwestern Medicine Proton Center. But the reason I tell you this is because our system is built was a ProCure system and has a configuration that's common in 4 other centers within the U.S. We also collaborate, of course, with downtown Northwestern Memorial Hospital, and we have physicians from Loyola and Rush on site here also that practice here. And even though we are called the Chicago Proton Center, we're not really located in Chicago. We're actually located about 30 miles west in the suburbs of Chicago. And this is a little overview of the center, and right next to us is the Photon Cancer Center right next door. And this is a nice picture of our center in the very few days where we have nice weather in the Chicago area, but a nice looking place. And we do have a 4-room center. So like I said, we're one of these ProCure centers. So we have 1 gantry room, we have 1 fixed beam room, and then we have 2 of these incline beam rooms. And I'll tell you a little bit more about these here. Of course, a gantry, I think most of us are familiar with, that we have a 360-degree rotation full gantry. The other thing, the couch can rotate around and give us full flexibility. And we have an IBA system, so we have quite a bit of flexibility on this gantry system. Now, the reason we only have 1 of them is because of this. This is the hardware that sits behind the gantry that you guys are aware of. And just to give some scale, there's a person down there in the corner. And to save cost, that's why we only had 1 gantry built into our system. Now, we also have a fixed beam room, which this little graphic shows some of the flexibility of the robotics setup arm. And this room, we do have some flexibility with that robotic arm. And then we've also, to maximize the use of this room, we've also developed treatments in the seated position. The other 2 rooms I mentioned are called incline beam. They look a lot like a fixed beam room, but instead of just treating with the beam at 90 degrees, we can also rotate the gantry up and treat from 30 degrees from vertical. So it gives us a little bit more flexibility than just the fixed beam room. These rooms are also compatible with seated treatments also. And the way we do this and to keep costs down was, there's actually 2 fixed beam lines in the back of there. And then there's a nozzle that just rotates back and forth between the 2 beam lines, depending on which incident angle that you want. And so this is a much more cost-effective way to build a room than another large gantry. So like I said, a little cheap plug here. We've been open 10 years now. We treated our first patient in 10/26 of 2010. And so, we couldn't do this without, I want to give a little thanks out to actually all our physicians and all of our great staff, therapists, nurses, and physicists, intake people, research people that make this place the great place that it is. So in the beginning, back in 2010, we opened up with each of the rooms with just aperture and compensator-based treatments using uniform scanning. So this is all we had. There was no pencil beam 10 years ago, and so we had this. Then the other thing that we really had for just our image guidance was just KV imaging that in the 2.5D method. So this was all that was available actually when the center opened. And of course, physicists and that group of great physicians all had a giant list of stuff that they still wanted. And those things included things, like right off front of volumetric imaging and surface guidance. We had lots of very positive experiences with both of these systems on the photon side, and we were kind of shocked that we would move to a proton system that doesn't have these things. We had a physician who really wanted to do ocular treatments, a group of physicians. So that was something that we didn't have right away. We knew about pencil beam scanning. It sounded like a great new technology, and it was something that we knew that could potentially allow us to treat more patients. We had limitations with just one gantry, so seated treatments was something that needed to be developed right away. And so with all that on our list to start off, it was, of course, a balance between time and money and what you could get. And so we kind of prioritized things, and ocular treatments was something that actually we could build a program here with relatively low cost by using a new treatment method. Pencil beam scanning was something that was really high priority because it allowed us to treat more patients, and even the patients we could treat better. And so pencil beam scanning raised very high to the list of priorities. And of course, with pencil beam scanning, unfortunately, then we needed a new treatment planning system. So a new treatment planning system was also another cost and time sink for us. With pencil beam scanning, we actually pushed our gantry and our fixed beam lines, or our incline beams, even more towards capacity. So seated treatments became a very high priority. And so with seated treatments, then we had to develop a chair to treat the patients in the seated position. And then we also had to install a vertical CT scanner so that we could image the patients in the seated position. So after all that stuff got done, now we're at the point where we're actually able to start thinking about surface guidance and volumetric imaging. Even though they were very high priority stuff from the very beginning, this is just where they fell in our development ladder. And so we did these things. This is a picture of an eye patient being treated in one of the rooms in the seated position. We upgraded our room 1 first to pencil beam scanning, and then our gantry to pencil beam scanning. And we've also upgraded the incline beam to pencil beam scanning. And this is a little movie of our chair, and you can see in the upper left that's our CT scanner, and then the treatment room. The treatment nozzle right to the right. So we did finally get the funding in 2020 for surface guidance, and so this was a really great thing. So we got the funding and we installed 3 C-RAD systems into our center. We installed one into the gantry, and specifically focusing on CSI setups and breast setups. We installed one in the PBS dedicated now incline beam room, where we installed that room too, and also to address breast setups and extremity setups. And we also installed a system, and Chen's going to talk some details about this, into our CT room, not just their 4D system, but also a surface guidance system to help on CT setups. And actually, good news is we actually acquired a 4 system recently, and we plan to install that in one of our remaining 2 rooms in the very near future. So in the gantry room, this is our gantry room. The couch sits in this area here, and remember, you have the nozzle that can rotate around the patient on either side. And so our cameras need to be placed in areas where you can get a view of the patient at all times. And so this kind of setup is actually pretty common. It has to be pulled outside of the rotating gantry on an IBA system. And so this is the pictures of the setups and a picture on the other side of where the cameras are, and to get a good view of the patient at all times. Now our incline beams, they look more like a half gantry, right? So the nozzle points in this direction, and the couch is able to rotate around the patient. Around the nozzle. The couch rotates around the nozzle. And so this is more like a half gantry. And so the camera positions then need to be placed so that we can see the patient in all those various couch positions at all times. And so the camera systems in this room then placed here in these scenarios. And you can see, especially on this picture, how we have to put it very close to our our X-ray imaging system, and it was kind of a tight fit all the time. And then this shows actually the gantry up at 30 degrees, where we can also, even though the cameras still can see the patient during treatments. So what are our needs? And this is kind of specific to when we're treating with protons. And this is very basics that the physicists worry about. So one is we gotta always hit the target. So we have to aim at the target, and we have to hit the target. So we need to know where it's at, and then aim at it and hit it. Now, the unique thing to protons, and this is what proton physicists spend all their time worrying about, is we also have to hit in depth. And so that means that we have to have consistent path lengths so that we actually have the protons stop where we think they're going to. And here's kind of an example of this. This is a patient, like a superclap patient. And if the beams are coming down from the top, I hope you can imagine that if the shoulder is moved up or if the neck is kind of twisted, we actually can kind of crunch all that stuff to the tissues together, and we can actually change the thickness to the bottom, the distal part of the target, and then we can have a miss of that target. So this is something actually that proton physicists spend much of their time always worrying about. So patient alignment consistency is that essential thing for very good quality proton therapy. So how do we make sure that the patients are set up? The historical part is using, going back a long ways, just using 3-point clinical setups. So 3 points are placed on a patient, and we triangulate an isocenter position, and that's how we align that patient. But we know that there's a lot of limitations of this, that skin markers are not a direct surrogate of the internal anatomy. So just because you're lined up on these 3 marks doesn't mean you're going to hit the target. The markers in the target can change throughout the treatment course. And so this often requires that we put permanent marks on the patients, like little tattoos that sometimes are very, patients aren't happy about. So if you can imagine, this is a 3-point setup, and to align this patient right here, in that 3-point alignment to triangulation into the room lasers, may not be a real good surrogate on how well we actually set this patient up. And then we can do some tricks where we actually place maybe another set of 3 points in different spots. But you can kind of see here, I hope you can imagine in this breast patient that her left arm and her right arm have very little to do with these setup marks. And so we can't guarantee that just because the setup marks are on that she aligned up well. And actually you can see her chin and her neck, which are very essential parts for these breast treatments, that these need to be in the right spot, and those marks have very, very little to do with the positioning of the chin. So there's other ways besides just the marks, and we do better than that. And we have X-ray imaging. So we can do planar imaging, and this allows us to see bony anatomy and align to bony anatomy. Our current systems they're very clever. They can actually, of course, do translations, but they can also correct for rotations of the patients. The X-rays do give ionizing imaging dose to the patient, so it's just not a free shot. We actually we pay with some imaging dose. It is a temporal snapshot also. We take the X-rays, and that's not necessarily the scenario where the patient will be during treatment. And we do have limited fields of view. So, for example, like in a CSI, we could be taking these head cases, but we don't know at all what the hips are doing when we have to treat that whole area of the patient. So there's some more improved imaging, and that's volumetric imaging, where we do either cone beams or CTs. And this allows us to not only see the bone, but also the soft tissue. So we take a CT, place it onto the treatment planning CT, kind of showing here in the picture between the orange and the gray. And this allows us to do translations and rotation corrections again. It unfortunately gives more imaging dose than just the KV planar moves. This is still also a temporal snapshot, just a moment in time. And again, we have limited field of views where we may or may not, we may cut off an arm that is important to know where the positioning is. And so this is the common scenario. I hope you can see the difference between an orange, which is one image set, in the gray. They're overlapped onto each other and registered. And these areas, that an X-ray image can do great at aligning these and translating them. and rotating them. But what do you do in scenarios like this where just the arm is not in the right spot? Or you can also see on the neck isn't in the right spot, so there's probably a head tilt problem. And so these problems are like real problems that you can't. The only way to really fix them is to go inside the room, fix the patient's arm, and how much you don't know, and in which direction we're not. You make a guess, and then you re-image the patients. And so that gets us into our loops of multiple X-ray image sets that actually really increase the ionizing dose to the patient. So the great thing is that we have a really, really nice tool, and that's surface imaging. So surface imaging uses 1 to 3 stereoscopic cameras and produce a 3D image of the patient. And then the surface of the patient then is compared to the surface that was taken at the time of treatment planning, and you can compare these two surfaces and correct the patient's positioning. The C-RAD system actually also has some real nice features where it actually shines a light in the areas where where the error is large, and actually even guides you whether it needs to be closer or further away. So the therapist can actually either look at this screen that I'm kind of showing here to fix the patient, or they can actually get live right on the patient, get some clues on how they need to move the patient to get it set up. The good part about this stuff that it is live time, so it gives direct feedback to the therapist right away. And there's lots of benefits that if we have this constant picture, these infinite set of eyes on the patient all the time, that it can really help us. And so where we get those improvements is through setup accuracy and consistency. So we have a whole bunch more information before we start taking X-rays to get the patient set up well. That reduces the time because we can get the patient's arms and neck in position into the right place right away. It reduces imaging dose because we will be taking less X-rays hopefully because we'll get them in the right position faster. We can also use the system for intrafraction monitoring. So since we have these cameras on the patient, why not just keep them on all the time so that we know that if the patient coughs or anything that if they've moved out of position or if they've stayed in the right position. It also gives us options to do gating because now we have some surface information and we can use that as some type of surrogate to the position of targets, moving targets, and we can gate the beam. So I hope I've given you a little bit of an overview of where surface imaging fit into our center. And I want to introduce Chen Liu here. He is one of our superstar physicists here. He's been with us a little over a year now, and he is the one that is he's our clinical lead in surface imaging. So I'm going to hand the podium off to him, and he's going to tell you a little bit more details about how we use the system. All right. So Chen.
Okay, thanks, Mark, and hello, everybody. So today I will be focusing on these 4 applications, and as well as sharing some clinical cases, just to kind of show how we found surface imaging has been very good tool in terms of improve patients' overall treatment quality. I will also be sharing some clinical challenges and the potential solutions for those applications. So for breast treatment, we know the common setup challenges are including this inconsistency alignment between chest wall and arm and shoulder position, especially for those patients with supraclavicular involvement. It also affects our X-ray imaging due to the breathing, and we often have to introduce this X-ray permanent marker to the patient's skin. So when we have the surface imaging available, we quickly adapt it for our breast patient. So the way we use it is as an additional tool in terms of the clinical setup. So we pretty much set up the patient we put the patient on the table and drive to set up. And we apply this 6-dimensional shifts from our C-RAD system to the PPS to the table. And by this time, we have the ability to adjust patient's posture on live. This is really nice because without surface imaging, we would have to do this loop of KV imaging to continuously adjust patient's shoulder and arm. But with surface imaging, we can real-time adjusting those those positions. So as a result, we have been using this for almost 6 months, and we applied it pretty much for all of our chest wall patients. And as a result, we have found that the residual shifts or the corrections from the surface imaging based on X-ray are much smaller compared to the 3-point imaging, compared to the 3-point clinical setup. So also, the average images reduced is about 3 to 4 images per setup, and normally we can get the patient set up in 2 sets of imaging. And the average time reduced is about 5 minutes per treatment. So moving forward, actually we since therapy are started to getting used to the surface imaging, we actually had our first patient simulated without any tattoos. So we are confident that we will be set up the patient good with surface imaging only. And we are also considering setting up treat the patient with surface imaging only, and I will talk about that more in the detail later. So some clinical challenges we've encountered for breast treatment is we do treat breast patients in both incline beam and gantry room. And due to the geometry limitation, we can only place the 3 cameras in the gantry room superior to the isocenter. And we know the ideal spacing between those 3 cameras are about 120 degrees. So it's kind of like a one inferior camera and with two superior oblique positions. So, but due to that limitation, we pretty much can only spacing the cameras to 44 to 45 degrees from each other. So in addition to that, as the patient going through their treatment, the skin color gets darker, and we may lose some extra information other information about patient's chest wall. So this is an image. This is probably the worst case scenario, but this is an image we got from a patient setting up for breast patient setting up in the gantry room. As you can see, we are missing a big chunk of information from patient's chest wall. So a couple solutions for that is first, we want to increase the region of interest for the surface imaging, even though we are not treating the surrounding tissue, but it offers the C-RAD to more sample data to calculate the overall shift to offer you a more consistent shift. So you probably also want to adjust the camera exposure time on the fly, because as the patient goes through the treatment, the skin gets darker. So you want to increase that time to compensate that less reflection from the skin. So first thing is KV imaging is always a good idea if you found something you're not sure. And if we are, as I said, we are considering treat with surface only. And another thing we should consider is the place patient feet first device, so we can have a much better imaging angle for the surface imaging for patients treated in the gantry room. So next thing I want to share with you guys is cranial spinal irradiation treatment. As a Proton center, we do have quite a bit CSI cases. So they are complex because we have these multiple isocenters to cover the whole treatment volume. And one common thing we do at our center is that we will verify this all isocenter position. We'll verify the entire body position by film done before the treatment. I hope this animation can show you how we do that. So we set up a patient at the head isocenter first, and we take an X-ray, and we make a necessary adjustment, and then we shift the patient to the second isocenter and then take another X-ray to verify the upper spine is within tolerance. And we'll do the same thing for the last isocenter to make sure the lower spine is within tolerance as well. And then we go back, we move the patient back to the first isocenter. And at this time, we know the entire body are set up, and we can start the treatment. So we'll take another X-ray, verify the first isocenter, and treat. We'll shift the patient to a second iso, verify, and treat. We'll do the same thing for the third isocenter. So as you guys can see, this process is quite time consuming because really due to the limitation of the imaging size. But with the surface imaging, we have a much longer volume. We have a much longer imaging size. And the idea of that is we set up the patient at the first isocenter, and we can look at the patient's entire body position by using the surface imaging. And we will make the physical adjustment based on that. And hopefully we can get the patient, hopefully we don't have to do that pre-film process before the treatment. So we kind of implement this as a safety with a safety measure. So we have this like a two-phase setup. So for patient first 3 fraction, we will both correct the patient posture based on the surface imaging, and we will also do the pre-film to verify the spines at all isocenter are within tolerance. So this is on the right hand side. This is just a detail of our clinical procedure with the tolerance table. We will also capture a new reference image as needed, and we kind of take the first 3 fractions as our comfortable level built-up region. So once we started on the first, once the patient set up good from the first 3 fraction, start on the 4th fraction, we will set up the patient without film down process, and we will treat. We'll pretty much do set up, treat, and set up, treat. So we don't have to do that pre-film down process. And this is a detail of our tolerance for the new procedure. So here's a little bit early result for our study. So I think started from July. We started this program in July this year, and we have a total of 12 CSI patients, and 8 of them works really good for that technique. And here's a summary of the translation shift for those patients that using C-RAD for their body posture correction. So we can see the average translation shifts are all within 2 millimeters with about 1.5 millimeter standard deviation. And we also found that the average time reduced for first of all, if the patient set up good, we're using the C-RAD. The average time we can reduce for each setup is about 15 minutes. And the average imaging we can reduce is about 3 sets of kV imaging. And we also found that the technique works better for lower body mass index patients, which makes sense because their surface represents their bony anatomy better. So yeah, that's pretty much it. So next application I would like to share with you guys is extremities. So this is a patient currently under treatment with a sarcoma on her thigh. So without surface imaging, it takes us about 5 to 10 minutes to set up based on the markers, and it often not very good. So it also takes us about 5 to 7 sets of kV images to correct that posture, because without a real-time feedback system, it's really hard to correct the posture based on the kV imaging. And sometimes it also requires multiple QA/CTs to verify the treatment volume is consistent. So with surface imaging, we really have this opportunity to adjust patient real time. And this is a really nice picture captured from September 29th. As you can see, the reference data is really in perfect agreement with the live data. And as a result, we can reduce the setup time by about 10 minutes by using surface imaging. And the average imaging reduced is about 3 sets of kV images. And then in addition to that, we have this opportunity to verify the patient treatment volume by looking at this bilateral surface. As you can tell, like if the patient volume changes, you can definitely tell from the surface. from by looking at this bilateral surface of the leg. And of course, we feel like there's no point to use tattoos for patients like that. So we may future eliminate tattoos for those patients. So here is challenges we've encountered in our incline beam room. So it not only applies to the extremity treatment, it pretty much applies to all the treatment that with a different couch angle. So when you have a different couch angle in your incline beam room or half gantry room, coordinates between C-RAD and the IBA PPS system is a little bit different. So I would recommend if you have a similar setup, I would recommend you to come out a conversion table for therapy team to convert those value from C-RAD to your PPS system. So for example, when we set a patient at 0 and treat at 270, our longitudinal shift from C-RAD is actually the opposite direction of the X shift in the PPS system, in the IBA PPS. So, which could be very confusing when we have the patient on the table. So this is an example of conversion chart we have in our room 2. So the last application I would like to share is the QA-CT rescan. So a common problem for that is in the CT room, you setting up the patient to their initial treatment position is very hard without any KV imaging system. And we also have this routine QA-CT to verify patients' anatomy and setup. So as a result, when you recalculate the dose in the TPS, you will find sometimes the CTV or PDV coverage has been dropped due to this poor setup. So since we have a catalyst system installed in the CT room, we can easily set up the patient to our surface imaging and before perform the QA-CT. And it has been found that the better agreement between QA-CT and the TP-CT in terms of positioning and the dosimetry. So one lesson we learned from for that application is that you do have to make a QA plan for that in your surface in your C-RAD, because the isocenter between treatment isocenter and the CT isocenter are different, and you could not shift your table from in the CT room. So by creating a QA plan for in the CT room allows us to set up the patient at CT isocenter. So moving forward, so we kind of already started doing this intrafraction motion monitoring. So the idea is to make sure the patient doesn't move after therapy left the room. And also, if the patient moves, we want to make sure that, we can quantify this motion. And another thing we will apply is that respiratory motion management, such as gated treatment or breath hold treatment. So in summary, we believe surface imaging improves our treatment accuracy by improving initial setup and the ability of monitoring intrafraction motion. It also improves our treatment workflow by decreased setup time and decreased imaging dose. For some patients, we can also decrease their tattoos. And in the future, we also think it can improve our clinical outcomes by applying gated treatment and the breath hold. So some lessons we learned. So really the major challenge you have is you will have a delta between, you will have a shift between your surface imaging system and the KV imaging system. And it could due to multiple reasons. Really, so you want to think about it, like when you have some situation like that, you want to think about like, do you have enough surface imaging volume to compare, or do you have too much surface volume to compare? And it is kind of set specific. So also you want to you probably want to adjust your camera settings on the fly, since sometimes the patient's skin gets darker during the treatment. So a good reference imaging is also required, and we have found that the room temperature reference imaging is better than the reconstructed surface from CT. So there's also this geometry limitation, such as the camera position in the gantry room, and we will have that limitation by because of that. And for some application, your surface just doesn't always correlate with your target very well, such as prostate. And with that, I would suggest you have a patient selection based on your comfortable level, because we know they are not going to work for all the patients. And I would also recommend to develop your own set specific workflow. Whether you want to treat it, whether you want to use the surface imaging as a setup tool, or whether you want to use it as a treatment monitoring tool, or both. So communication between physics therapy and the MDs are also important, and I feel like there's a steep learning curve for all of the parties, and the physics should support therapy as much as possible. So with that, I would like to say thank you for your attention, and let us know if you have any questions.
Thank you, Mark and Chen, for the wonderful presentation. And so we have some questions from the audience. The first one is, what are your thoughts on correlation between internal and external anatomy? Are there any studies have done for this topic?
So what we found is for breast patients, the correlation surface and the bony anatomy are very close. And for and if not very close for prostate patients. And we know there are a lot of studies published data with kind of to prove that as well.
Okay. So another question is about, so are there any interoperability between the surface system and the OIS and IBA control system? For example, are there any interlocks between those systems?
Yeah, so there is with IBA. Unfortunately, it's a additional thing that you need to buy. It's always additional cost. So there is a universal triggering interface that you can buy on the IBA side that would trigger the beam off in based on the tolerances that the C-RAD was monitoring. We don't have that right now. Yeah, we don't have that, so we kind of have to have the therapist keep an eye on stuff and with their hand on the button ready to shut it off.
Mm-hmm. So right now you have manual. It's kind of a manual interlock. Okay.
Yeah, fully manual interlock.
Okay. So next question is, can you think of any interoperability that would be used with your TPS system? So can this be like upstream in TPS? Do you have anything you can think of that can improve with the surface guided?
Actually, I hadn't really thought about that. That's kind of interesting. Actually, you may be a better person to ask this for, especially, with some of your, with some of your reconstruction methods that you kind of have for the on treatment QAs, some of the work that you published specifically. If those surfaces could somehow be correlated with some of the kind of the tricks of the work that you had, I think there's potential. There is some potential inside of that. The surface imaging does give you, the one thing that would be good is if you do have just a cone beam volumetric image, your field of view may cut off lots of stuff, and so you lose a lot of information there. And then if image registrations from treatment planning CTs, the cone beams if they could be guided a little bit potentially with surface guidance to kind of help that registration and the crossover of Hounslow units into the cone beam, in the cone beam realm, then potentially, that could be a huge help, because that is some additional information. And like Chen said, it's a much larger field of view usually. But there's nothing like that now. But I think I think there's potential there.
Yeah, I think this is a good question. Maybe in the future, the surface, like the images, can be feedback to TPS, and then TPS can use this as like a baseline to reconstruct the CT, and then do a QA-CT, perform a QA-CT basically a purpose, and see if a replan is needed.
Yeah, it is valuable information